goal stage 3, this is more severe. These are the ones we generally end up hospitalizing for exacerbations. And there we have a predicted FEV of 30 to 49%. And they have marked dyspnea, so even on a level play, they find it difficult to walk. They have to rest frequently. And finally, our goal stage 4s, which is very severe, and that's a predicted value of less than 30%. And they often require, these patients often require home oxygen. So the prognosis is multifactorial, and that's what we're going to get to now, not just stage dependent. So we're going to go to the fact is, we also have to look at symptoms for patients when deciding on what treatment they now go on. So we use 2 scales, and we can use the Modified Medical Research Council Dyspnea Scale, and that's basically graded 0 to 4, and depending on your score, 0 to 1 is a low symptom burden, and anything from 2 and above is considered high symptoms. And then we have the CAP, the COPD assessment test scores, and then we have, as you can see, 8 of these parameters. Each one is graded 0 to 5, so 5 8 is 40, and we can calculate the points. 0 to 9 is the low impact, 10 to 20 medium, greater than 20, 21 to 30 high impact, and 31 to 40 is considered very high impact. And what do we do with these scores once we calculate it? So this is part of your assessment. When you first see the patients in the room, after you've diagnosed COPD via spirometry, now we can look at symptomatology. So these are part of our electronic health records. Now I thought I'd include this slide as well just to see what's out there and what's coming. And these are basically the biologics in COPD, which is what everything is going to. I think our colleague with gastro as well will also see inflammatory bowel disease, biologics, and our pathologists in the rooms as well will also tell us that's changed the way they practice their craft. So that's also occurring in COPD, and there are various mechanisms by where they exert their influence. And we can look at the TSLP, so we are involved currently. We are doing the trials for tezepelumab, as well as we've done the trial for dupilumab previously. And the outcomes or the results that we're seeing in our patients with COPD at the moment, obviously we don't know whether it's placebo-driven or whether the patient's getting active drug. But with dupilumab in particular, we were involved in the NOTICE trial, and there we had excellent results. The patients actually really developed those aspects. So as we see with the anti-TSLP, that is the primary stromal lymphopoietic precursor. So if we block that with the tezepelumab, we block the downstream inflammatory cascade. And that will lead to obviously less goblet cell hyperplasia, airway remodeling, as well as less mucus production. So they have fewer exacerbations. That's what we find in these patients. Secondly, what we do also find is that they actually improve on their lung functions. So the whole biomechanics of breathing improve with using these biological agents at this point in time. Pembrolizumab is also recently been approved in some jurisdictions with the FDA for those patients with hyper-eosinophilic type or phenotype of COPD. So this is the future. It's just at the moment way too costly. So hopefully with time that will